Shall we start?
Yes,
Yeah,
ma'am. Yeah.
now we are on live. We can start, madam.
Uh,
Over
okay.
to Dr. Kochi.
Okay. So good evening, doctors. I am Dr. Prachi from Shield Healthcare, and a warm welcome on behalf of Shield Healthcare. Good evening, Dr. Abida Pavin ma'am,
Good
and
evening.
thank you for accepting our invitation. So it's my pleasure and honor to introduce Dr. Aabidha Pavin. Ma'am is MBBS, DNB, PG, DMCH, CCUSG, and FRM. Consultant obstetrician and gynecologist, sonologist, infertility specialist, and certified laparoscopic surgeon, working in Crescent Multicare Clinic and Nelai Multicare Clinic in Tamil Nadu. Ma'am has participated in many webinars and conferences as guest speaker, conducted many health camps and health education programs for schools and college students. Mom has many publications, including an international paper on outcome of pregnancy in preeclampsia, and also paper on vaginal hysterectomy versus abdominal hysterectomy in rural health setting in Rural Surgery Journal. Mom is recipient of many awards, including Seva Ratna Award received in April 2017 and in August 2019. Also, MAPOSI Award, then Kamban Award for contribution to Tamil literature, Best Doctor Award from Rotary Club in December 2018, and also Samugai Sevai Simmal Award from South India Social and Cultural Academy in June 2019. With this, may I request Ma'am to deliver her talk on UTI and women's health. Thank you very much. Over to you, Ma'am.
Thank you so much, ma'am, for your kind words. And I am honored and privileged to be in this webinar. And I'm very happy to be a part of this webinar. And I thank Shield Connect for doing this wonderful job and giving us an opportunity to create this health awareness among doctors and in knowledge sharing. Thank you. Actually, this is an must awaited webinar. And it is the this is a common thing. What we are going to talk on today is about urinary tract infection, which we see in day-to-day life. In general OPD, we do come across many patients with urinary tract infection. Some may go treated, some treated with difficulty, some are inadequately treated. So patient come with variable complaints. So this is one common topic which every gynecologist come across in their day-to-day OPD practice. So coming to the urinary tract infection, it is actually an infection occurs when bacteria invades the urinary tract. Among all the infections in our body, this is the second most common infection. And specifically, women are more prone to UTIs than in their male counterparts. Male counterparts get their urinary infection only during less than 1 year age and more than 50 years age. But during the reproductive age group, women are more prone to UTIs than in men. So coming to the incidence, actually adult women, they encounter UTI in 6 to 10% per year. In pregnancy, it is much more higher actually, 4 to 10%. That can affect baby. It can lead to preterm labor. It can lead to chorioamnionitis. So it is best to be treated. This asymptomatic bacteriuria should be evaluated and treated in pregnancy in the earlier period itself, earlier gestation itself. So if we catheterize a patient, that gives an added risk to the patient. So there will be in normal patient, the risk of UTI is 1 to 3%, but in the more sicker and vulnerable patient, it is 10 to 15%. So overall, as we said before, female and male ratio, overall ratio is 10 to 1. Female are more prone to get UTI, 10 times commoner than men. But the incidence of UTI is more in men during, that is in the newborn age group, that is less than 1 year, and in more than 50 years, that is in the elderly group, male group, male outnumber women in UTI. So coming to epidemiology, we see asymptomatic bacteria in many cases, and that progresses to acute cystitis in 1 to 4%, and acute pyelonephritis, that is infection reaching the kidney, in 0.5 to 2%. So the incidence of bacteria in pregnant women is slightly higher than non-pregnant women. Progression to pyelonephritis is also significantly higher in pregnant women, as their immunology will be low. So coming to the predisposing factor, the commonest cause being obstruction. Either any the calculi is more common even in younger age group in this era, because people like tend to suppress urine. They don't go to toilet often. School children itself, we see many school children in the age group of like 10 to 14 years with much calculi. And the other causes being tumors, benign prostatic hyperplasia in male, and some extrinsic mass in female. It is the more common is any fibroid in the cervical fibroid or ovarian cyst compressing the ureters can cause UTI. And in male, vesicoureteric reflex, incomplete bladder emptying, either neurogenic or voluntary. And the commonest being diabetes. We see many diabetic women with UTI, sickle cell, and immune compromise. Blood instrumentation, when we put catheter, the chances of UTI is more. And any foreign body, if it is kept, it can predispose to UTI. And any congenital structural abnormalities in the urinary tract often can cause UTI. And sexual activity and pregnancy. So reproductive age group women and pregnant women, we see a lot of patients with UTI. So UTI can be diagnosed with simple dipstick test, gram staining. If we see one bacteria per high power field, it indicates UTI. And urine analysis with microscopy and urine culture and sensitivity, which is the gold standard in diagnosing UTI. So these are all the common laboratory investigations we do. And what are the organisms which we see in UTI is E. coli, the commonest being 63 to 85% we come across E. coli. Then comes Klebsiella pneumoniae in 8%, Coagulase negative Staphylococcus up to 15%, Staph aureus up to 8%, and GBS, group B streptococci 2 to 7%, which is dangerous when we encounter it in pregnancy. So UTI common symptoms being adult, we come across most common symptom is dysuria. So there will be frequency, urgency, nocturia. They go twice, thrice, or 4 to 5 times in the night. There will be suprapubic pain associated with back pain, hematuria, cloudy urine, and enuresis. In babies, there will be lethargy. The baby can't tell anything. So there will be poor feeding, fever or hypothermia, vomiting, diarrhea, and there will be strong smelling urine. When mother come across foul smelling diaper or urine when the baby passes, like we have to be particular and we have to advise the mother to come to pediatrician immediately. Coming to the elderly, there will be malaise, weakness, vomiting, fever or hypothermia, most commonly confusion, hypotension, and urine retention. They suffer a lot with UTI. So actually, there are no symptoms or signs which can differentiate from upper or lower tract infection. If there is any respiratory tract infection, we can easily differentiate whether it is URI or LRI. But it is not so in case of urinary infection. We can't differentiate whether it is cystitis alone or pyelonephritis. When it is more upper, the pain is more upper, we can say it is pyelonephritis. And the differentiating feature is suprapubic pain in the cystitis and flank pain in the pyelonephritis. And the fever grade will be low grade fever in case of cystitis, but in pyelonephritis, there will be high grade fever, 1 or 2, more than 1 or 2. So persisting for like more than 48 hours, then we can somehow come to a diagnosis. It can be an upper tract infection, but still there are no clear-cut symptoms and signs which can differentiate between upper from lower tract infection. So the most common clinical presentation being in recurrent UTI or recurrent and persistent asymptomatic bacteriuria. It can present as acute cystitis or acute pyelonephritis. If the primary asymptomatic bacteria, if it goes untreated, it leads to acute cystitis and acute pyelonephritis. So according to IDSA, Infectious Disease Society of America, significant bacteriuria in asymptomatic women. The women will not have symptoms of dysuria or nocturia, but when we do bacterial monoculture, if the colony-forming urine is more than 10 power 5 in 2 consecutive and midstream clean catch urine specimen, we have to educate the patient regarding collection of the urine while doing urine culture and sensitivity. We have to ask the patient to get it from a standard lab, a clean container, sterile container. There has to be they have to wash their hands properly. They have to take in the early morning sample, that too midstream clean clutch urine, because even the vaginal contaminants may contaminate the urinary specimen and will lead to false results. Or if we do a catheterization and we itself collect in a controlled environment, and if the colony forming urine is more than 10 power 2, then itself we can say it is a significant bacteriuria. But when a patient collects, we have to educate the patient properly in collecting the midstream clean class urine specimen. So coming to the screening, like asymptomatic bacteria, the pediatricians and ACOG as well as US preventive service task force recommend screening of bacteria at the first prenatal visit in a pregnant woman. When they come for a first visit, when the UPT becomes positive or at 12 weeks, we have to check for asymptomatic bacteriuria because we have to, because patient may not present with symptoms till when the colony count is more. So as a routine, part of a routine screening, when we do HB, HIV, like VDRL, we have to take urine culture specimen so that we will not miss this asymptomatic bacteria, because later in pregnancy, if it is untreated, it can lead to preterm labor, chorioamnionitis, like infection to the baby. If it is group B streptococcus, it can be dangerous to the baby as well. So if asymptomatic bacteria is not treated, approximately 40% of infected women will develop symptomatic infection during pregnancy, because pregnancy will maybe itself is a state where the patient will be in an immunocompromised state. So any infection can get easily into a woman. So the bacteriuria, asymptomatic bacteriuria can go in for cystitis or pyelonephritis in more than approximately 40% of women in pregnancy. So acute cystitis, in that there will be 1% of all pregnant women. It starts as an ascending infection in a long-standing asymptomatic bacteriuria. So common symptoms of acute cystitis is dysuria, frequency, urgency, suprapubic pain, hematuria, lower urinary tract infection with pyuria. There will be pus cells in the urine, and there will be whole-smelling discharge in the urine. It can be caused by even the culture can be negative. It can be due to urethritis caused by Chlamydia trachomatis itself. So coming to acute pyelonephritis is the most common serious medical complication of pregnancy, because it is the leading cause of septic shock during pregnancy. It is mostly unilateral in more than half of the cases, but in 1/4 of the cases it is bilateral. So coming to the pyelonephritis, as we discussed already, there will be abrupt onset with fever, shaking chills, aching pain, anorexia, nausea and vomiting. Tenderness will be below the ribs in the flank, elicited at the costovertebral angles. Coming to the microorganism in acute pyelonephritis, as it is an asymptomatic bacteria, E. coli contributes to 70 to 80%, Klebsiella pneumoniae in 3 to 5%, Enterobacter or Proteus in 3 to 5%, and gram-positive organisms including group B streptococci and Staph aureus in 10% of the cases. So coming to the diagnosis of acute pyelonephritis, we can't, as in cystitis, we can't do it in urine culture. So renal biopsy is the gold standard, but it is impractical in clinical practice. So we do with a combination of clinical and laboratory parameters. So combination of symptoms like flank pain, fever, high-grade fever which is not subsiding, and like suprapubic pain associated with suprapubic pain, renal angle tenderness, full blood count, and inflammatory markers, renal function test, blood culture, urine culture, and sensitivity testing. That gives a picture of acute pyelonephritis. So, what are all why we are more worried about this acute pyelonephritis? Why we are more worried about this asymptomatic bacteriuria, which can lead to 40% of symptomatic cases, that can lead to 1% of acute cystitis and acute pyelonephritis. But why we are worried, especially in pregnant women? Because it can lead to medical complications. Because these endotoxin, which are produced during this acute pyelonephritis, can cause lung alveolar injury, which manifests in 10% of women, can lead to frank pulmonary edema, which is detrimental in pregnant women. It may be severe enough to cause ARDS, acute respiratory distress syndrome, and this itself can cause hemolysis and anemia. Bacteremia will be developed, bacterial blood culture will be grown in 15 to 20%, and there will be transient renal dysfunction in 2% of the cases. That is why it is more detrimental both to the mother and the baby. That is why we are more worried about this acute pyelonephritis. Coming to the obstetric complication, it can lead to, as we said, it can lead to preterm labor, it can predispose to preeclampsia, chorioamnionitis, even postpartum endometritis. So coming to the fetal complication, we are going like medical, what are all the medical complications to the mother, what are all the obstetric complications. Coming to the fetal implications, there will be low birth weight. there will be preterm labor, so baby birth weight will be low, it will be less than 2.5 kg. Prematurity, that is 37 weeks of gestation, it can lead to preterm labor, the baby will be born earlier. Due to this, all this causes, there will be developmental delay and mental retardation in the babies, and it can lead to increased rate of perinatal mortality. Coming to the differential diagnosis of acute pyelonephritis, because many other causes, other conditions can lead to abdominal pain, flank pain with fever in pregnancy, which are all common as chorioamnionitis, appendicitis, placental abruption, infarctor leiomyoma, fibroid uterus also will mimic acute pyelonephritis in pregnant women. But doing an urine culture and sensitivity, like bacterial culture and the renal, like with associated with symptoms, will give clear picture of acute pyelonephritis. Coming to the management, actually asymptomatic bacteriuria, even if you see any bacteria in the culture, like more than, as we said earlier, more than 10 power of 5 or more than 10 power 2 in a catheterized specimen, we have to start treating the patient even if they don't show any symptoms, because this can lead to all the medical, obstetric and perinatal complications. So what are all the treatment available? Treatment are like single dose treatment, we can give amoxicillin 3 gram, ampicillin 2 gram, cephalosporin 2 gram, nitrofurantoin 200 milligram, trimethoprim sulfamethoxazole 320 per 1600 milligram. Either we can give any of these antibiotics in single dose treatment. If the patient is not tolerating single dose treatment, we can very well give 3-day course like amoxicillin 500 milligram TID, ampicillin 250 milligram 4 times daily, cephalosporin 250 milligram QID, ciprofloxacin 250 milligram BD, levofloxacin 250 or 500 milligram BD, nitrofurantoin 50 to 100 milligram 4 times daily or 100 milligram BG. Trimethoprim sulfamethoxazole also can be given BD. So these are all for 3-day courses, either any of these antibiotics, or we can give nitrofurantoin, which is safer in pregnancy. We can give 100 milligram QID for 10 days or 100 milligram BD for 5 to 7 days or 100 milligram only at bedtime for 10 days. Suppose even if we treat an UTI, like you give it for like single dose treatment or 3-day course or for 10 days, still we are getting colony culture positive, that comes as treatment failure patient. So in that case, we can give prophylactic nitrofurantoin 100 milligram QID for 21 days. That will be safer, which can prevent complication, all obstetric, medical and perinatal complication. So how to follow this asymptomatic bacteria? All pregnant women, once if you see, like when they come for a first prenatal visit or at 12 weeks, when we do urine culture and sensitivity, we see any colony forming units, we treat the patient. We should not leave with that itself. Should do periodic screening, because already they are prone to asymptomatic bacteria. So many of the, actually 1/3 of the patient will go in for reinfection. So in that patient, we have to do periodic screening every 1 or 2 months. We have to do an urine routine every 1 month, and every 2 months you can repeat one urine culture and sensitivity to see whether they get reinfected. And follow-up culture should be obtained 1 to 2 weeks after treatment, and then repeated. We have to once a month we have to repeat the urine culture and sensitivity. So some patients may come with persistent recurrent bacteria. How can we manage that patient? So we told like still we have given nitrofurantoin 100 milligram QID for 21 days. Still patient is showing cultures. Then what can we do next? So we can continue the nitrofurantoin 50 to 100 milligram at bedtime until the end of the pregnancy. So to prevent perinatal complication and obstetric complication, to prevent acute pyelonephritis, to prevent ARDS, pulmonary edema, renal damage, it is better if they come with persistent recurrent bacteriuria, we can continue nitrofurantoin 50 to 100 milligram at bedtime till the end of the pregnancy. We should not leave with that also. You have to do postpartum urological evaluation, because this patient with recurrent infection, they may have some predisposing factor. In that case, after postpartum, like we can refer her to a urologist. In recurrent infection, they're more likely to be any structural abnormality in the renal system. So urologist consultation is necessary in recurrent bacteriuria. So coming to acute cystitis, how we can manage this acute cystitis? We can increase the fluid intake, which is the first line treatment in pregnant women. We can give nitrofurantoin 100 milligram BD for 7 days, urine alkalinizing agent, and cranberry juice, which acts as an urine alkalizer. And it is used to treat the infection, and that will be dysuria will get relieved with this cranberry juice. Actually, this cranberry, it contains more vitamin C also. So it alkalinizes the urine, one thing. And the thing is, it prevents the biofilm to get adherent to the urinary bladder epithelium. Coming to the acute pyelonephritis management, we can, pyelonephritis, if the patient goes in for pyelonephritis, there will be high grade fever, which doesn't come out with OPD antipyretic. So we have to hospitalize the patient. We have to obtain urine and blood culture. We have to evaluate her hemogram because she can go in for hemolysis and anemia. It can cause renal damage. So we have to do serum creatinine and electrolytes, and we have to monitor her vital signs frequently, including the urinary output. So it is better to keep her on catheter. And with IV crystalloid solution, we have to maintain the urinary output with more than 50 ml per hour. So we have to start her on IV antimicrobial therapy. We have to do a chest X-ray with shielded abdomen if the patient complains with dyspnea, tachypnea, because we have to suspect ARDS in those patients. And we have to repeat the hematology and biochemistry studies in 48 hours. Once the patient gets afebrile, like you can days. And we should not leave by that. Repeat the urine and culture and sensitivity 1 to 2 weeks after antibacterial therapy is completed. So along with that, we have to give her NSAIDs for symptomatic relief, thromboprophylaxis if the woman has reduced her ability, because due to this UTI and pyelonephritis, if the patient gets bedridden, if she needs prolonged bed rest, we have to consider antenatal and postnatal thromboprophylaxis also. Compression stockings and low molecular weight heparin. If she goes in for preterm labor, tocolysis is frequently necessary if it is very earlier. But if it is in later gestation, if she is already in acute pyelonephritis, it is better to deliver the baby along with antibiotic cover. And in a preterm labor, it is threatened preterm labor, it is best to give antinatal steroids for fetal lung maturity. Coming to the antimicrobial of choice, if we want to give IV antibiotics in case of acute pyelonephritis, in mild and moderate, we can give ceftriaxone 1 gram every 24 hours, cefepime 1 gram every 24 hours, amoxicillin with clavulanic acid 1.2 gram every 12 hours, or aztreonam 1 gram every 8 to 12 hours. In case of severe acute pyelonephritis or in a patient with an immunosuppression or urinary stasis, it is better to go in for higher antibiotics like ticagrelor with clavulanic acid 3.1 gram every 6th hourly, piptaz 3.375 gram every 6th hourly, or meropenem 0.5 gram every 8th hourly, or ertapenem 1 gram every 24 hours, or doripenem 1 gram every 8 hours. So these are all the category of drugs which are safer in pregnancy, as we said already. And coming to the newer antibiotics, we have fosfomycin, which is a newer antibiotic that can be taken as a single dose. It is a broad spectrum antibiotic. It is produced by streptomycin species and has bactericidal action. It is given as a single dose of 3 grams sachet. It is a category B drug, cost is more. If acute pyelonephritis does not respond to treatment, it becomes persistent acute pyelonephritis infection. In that case, like we have to give IV hydration and antimicrobial therapy. We have to bring down the temperature at least 1 degree Fahrenheit per day. If it is not coming down at least 1 degree, it should be, we have to make it lower. But still, if 48 to 72 hours, the patient doesn't show any clinical improvement, we can suspect urinary tract obstruction, or it can be a persistent infection. The causes of persistent infection being, as we said earlier, it can be a urinary tract obstruction or abnormal urethral or pelvic calyceal dilatation, or it can be an intrarenal or perinephric abscess, or it can be a nephrolithiasis. So in that case, we have to do ultrasound KUB, one shot IV pyelogram or MRI to detect the cause of persistent infection. Obstruction relief, if with the help of urologist, you have to place a cystoscopic double J urethral stent or percutaneous nephrostomy in case of pus in the kidney, or surgical removal of the stones, which is mandatory if it is detected in the mid-trimester. So some patient will have like low count bacteria or even negative culture, but still they recur. This occurs because there is an intracellular bacterial colonies forming a biofilm. So that the bacteria will be inside the bladder, forming a biofilm like outer like armor like weapon. So we cannot detect that bacterial culture in the urine culture, but still patient will have bacteria in the urine and the patient will have symptoms. So in that case, the biofilm usually E. coli, uropathogenic E. coli, will invade the urothelial cells lining, which forms the intracellular bacterial communities or biofilms. This remains undetected in the normal urine culture, and there will be recurrent urgency and dysuria, unexplained urgency and dysuria in the pregnancy. In that case, which is termed as culture negative infections, are often termed as interstitial cystitis or bladder pain syndrome. So this is how we see what are all the culture positive, culture negative. See here in this culture positive, we see bacteria outside the bacterial cell wall. So we can detect this bacterial cell. It can go in for an fragmentation, fluxing, filamentation. It can be easily detected. But in this intracellular bacterial colony forming units, the bacteria goes inside the cell. It forms a biofilm, which will not be detected in the urinary bladder. When we do urine routine or urine culture, this colony forming units will not be detected. Even though they go for sloughing, they go along with one biofilm like layer, so it will not be detected at all. That's why culture comes negative, but still patient pain comes with dysuria and recurrence of infection. So, in order to prevent this recurrent infection, we can, as we said already, antibiotic prophylaxis like nitrofurantoin 50 to 100 milligram OD at bedtime can be continued till the end of the pregnancy. And we can ask them to take 150 to 70 ml of cranberry juice or concentrated equivalent in preventing the recurrent UTI. You have to maintain the local hygiene because vaginal infection, white discharge, like pathological white discharge can cause recurrent UTI, and patient has to take adequate amount of urine water, 3 to 4 liters of water to produce more urine so that bacteria gets flushed away. And women who are sexually active can be advised to follow postcoital voiding. So conventional treatment will be like we will give the patient for burning micturition, we will give one alkalizer. For pain, we will give one fluoxide, and for recurrent, to prevent that recurrence, we will give cranberry juice. So we have got a new simplified solution, that is UTI flush. I have been using this UTI flush for the past 6 to 8 months. I am getting an excellent result with this. That's why I choose this urinary tract infection. And patient even in pregnancy they come with excellent, and this is like palatable, like patient takes because when we give alkalizer solution, any alkalizer solution, particular solution, patient comes with vomiting. Already pregnancy itself will be prone to more excessive vomiting sensation, nausea, but this UTI flush is so palatable, patient takes it and this is one wonderful health supplement. It relieves pain, burning micturition, and it prevents recurrence also. How this ursolic acid in the UTI flesh is a powerful anti-inflammatory and analgesic. This anti-inflammatory can be compared to indomethacin, but it is indomethacin we cannot give in pregnancy, but this ursolic acid can be given in pregnancy. Similarly, potassium magnesium citrate, which normalizes the pH of the acidified urine in the infected urinary tract. That's why it alkalinizes. And similarly, cranberry extract, it exerts anti-adherence property. It prevents the bacteria to get adherent to the uroepithelial cells. And the D-mannose it also exerts anti-adherent property. So we have a one-stop solution of relieving pain, burning micturition, and recurrence. So for burning micturition, pain, and recurrence, one simplified solution we have got, like for acute painful UTI, we can give one sachet OD for 14 days, and for recurrent UTI, one sachet OD for 28 days. Still, if they come with recurrent bacterial culture positive cases, we can continue nitrofurantoin 100 milligram OD at bedtime till the end of the pregnancy to prevent medical, obstetric, and perinatal complication. Thank you. Your questions are always welcome. And once again, I thank you, Shield Connect, for giving me this wonderful opportunity for sharing this knowledge to the doctors and for the entire community. Thank you very much, Dr. Prachi,
Yes.
and I thank the entire manager and Cherry Healthcare Pharma for creating this webinar and continuing with this webinar regularly. Thank you very much.
Thank you, ma'am. Thank you very much. Thank you for your kind words and encouragement also. And the presentation was very good. Ma'am, if you have, if there are any more questions, I will definitely read out those questions to you.
Yes,
ma'am, my first question from me, basically in your regular practice, ma'am, how frequently do you come across to asymptomatic patients in antenatal visits?
as asymptomatic bacteriuria, if we see like 10 patients in OPD, at least one to two in OPD, we get urine culture positive in pregnancy, actually.
Right. So that's a pretty high. I mean, at least
yes,
around
yes.
20%, 20-25%.
That too, in this in this climate, warmer climate, no, like March to May, we see a lot of asymptomatic bacteria, and with symptomatic cystitis also we come across.
Right. And it's a regular practice to check the at least a dipstick method to check the.
Yes, ma'am. We do like in antenatal visit, first antenatal visit itself, along with other investigation like routine hemogram, sugars. We do urine routine, and at least once in pregnancy at 16 to 18 weeks, we do urine culture and sensitivity routinely.
Right, ma'am. Thank you very much. I'll just check the additional questions.
Fine.
Venkatesh, are there any additional questions?
Actually, no.
Sorry?
No questions, madam.
Okay. Right, ma'am. Currently, there are no additional questions. So thank you very much for that excellent presentation and all your support, ma'am. Ma'am, any additional patient subset can you recommend, especially for the UTI flush?
No, I'm not getting your question, ma'am. Sorry.
Specific patient subsets wherein the Shields product would be excellent to utilize.
Other products you're asking? No, UTI flush.
UTI flush, yes.
UTI flush, like for past 6 to 8 months, I am using them. It is with excellent result I am getting. The thing is like more palatable. Yes. That is one common feedback I get from the patient.
Yes. Both symptomatic and asymptomatic in both.
Yeah. Symptomatic also they get like after like taking 2 sachet like 2 days after 48 hours they have excellent symptomatic relief. Even with a patient with a dysuria and nocturia, if they give UTI flush like within 48 hours after 2 sachet, they give nice feedback that the dysuria gets relieved.
Correct. And because it is a good test, probably the vomiting is no.
Yeah. Like pregnancy, we have to be safe. If we give any other alkalinizing solution, patient will come with vomiting, and they will end up in like a hyperemesis only. So in that case, like UTI flush is like a blessing to us only. Thank you.
Thank you, ma'am. Thank you very much. Thank you for those encouraging comments and the feedback.
Thank you.
Thank you, ma'am. So with this, we are closing today's webinar. So thank you very much.
Thank you so much for the entire team who is taking part. Thank you.
Thank you.
Thank you, madam. Thanks.
Thank you, sir.